My name's Naomi Barrett. I'm a Health Promotion Officer with New South Wales Health. You may know me as one of the face of the team at Caddyshack. We do have the rest of the team, Caitlin, Madison, and our famous team leader, Jen Farinella, online with us this morning. Myself and Dr. Kang will be presenting this morning, going through the top 10 Googled sexual health questions. So we would like to begin this morning by acknowledging the traditional custodians of the land upon which we meet. This morning I'm based here in beautiful Yuin country, and I would like to pay my respects to elders past, present and emerging. Just a nice little paragraph to read out for you to acknowledge those custodians, that as we share our knowledge and our teachings in this learning space today, may we also pay respect to the knowledge that is forever embedded within Aboriginal custodianship of country. I would like to pay my respects to elders past, present and emerging, and also welcome any Aboriginal or Torres Strait Islander person who is joining us today. So, the Dolly top 10 Googled sexual health questions. Today, I am a little starstruck. 12 years ago, as a rather new sexual health promotion officer, I walked into a GP working group meeting for Sexual Health Week at the Royal Prince Alfred Hospital. Opposite me was a beautiful smiling lady with the curliest of hair, the funkiest of glasses, who introduced herself as Dr. Melissa Kang. Very quickly, the penny dropped, and I realised that I was in the presence of one of my biggest teen educators. I recall buying my first Dolly magazine at a local news agency when I was in Year 7. Along with two of my friends, we rushed home and sniggled as we opened the sealed section and started to read things about sex that we never could have imagined asking our parents about. All I can say is thank goodness for Dolly Doctor. Dr. Melissa Kang starred as Dolly Doctor for an incredible 23 years, thus no doubt having some impact on the sexual health education of most of us present here today. In the past 12 years, having had the pleasure of working with Dr. Melissa Kang, I've learnt that beyond the fame and face of Dolly Doctor, she's a passionate GP who works with marginalised young people and who advocates for them when they often have very little voice of their own. That being with young people is what makes her happy, and that taking technical doctor jargon and turning it into meaningful language for young people and professionals alike is what she truly does best. This can be evidenced by her work with Yumi Stein in their book titled Welcome to Your Period. And we're very excited to announce the soon to be released and no doubt a hit selling book given our current climate titled Welcome to Consent, due for release at the end of this month. I've already pre-ordered my signed copy. I'm very excited to receive it. Professor Melissa Kang is a medical professional, devoted her career to being a GP working with marginalised young people within the Sydney suburbs, also being an academic and having many honorary roles at several Sydney universities. We feel privileged to have Dr. Melissa Kang here with us today as we undo the sealed section and no doubt relive some of those memories from our own childhood. Let's explore the most 10 commonly asked questions today and work through with the famous Dr. Melissa Kang. Over to you, Nell.
Oh, Naomi, that is just such a beautiful and over the top introduction and welcome. Thank you so much. And look, I was also a Dolly Doctor reader. I don't want to take credit at all for being the one and only Dolly Doctor. I was the medical person behind Q&A for the longest period of time, which was 23 years. But there were many Dolly Doctors before me from 1970 when the magazine actually launched. And I did stick with it right till the end. But there were other excellent health professionals who also contributed to that section. So I do want to acknowledge them. So thank you. Look, I would like to acknowledge the land on which I'm speaking to you from, which is Gadigal land in the Eora Nation, which is in the inner part of Sydney. And I pay my respects to elders past, present and emerging, and would really like to acknowledge and thank the Aboriginal and Torres Strait Islander people joining us on today's webinar. It's a real honour to be speaking to you from Gadigal land and just to be here talking to people from all around the state. Thank you so much for having me. So let's get started with the questions, shall we, Naomi?
Right. Let's just dig right in. So excited. All right. So our first question is, can I get an STI despite using protection?
Yeah, that's a great question. And it was a relatively common one that came through to Dolly Doctor for those young people who were already engaging in sexual activity, which wasn't actually the majority of readers, but it's certainly a common question and something that I do talk to clients that I see in my clinical practice. The short answer is yes, you can. But the longer answer is it does depend. And it depends really on the characteristics of the actual microorganism that are causing a particular STI. I like to think that with all the sort of difficulties we've experienced in the last 14, 15 months with the COVID pandemic, one thing that I've noticed has happened is I see around me, amongst young people, amongst colleagues who are not health professionals necessarily, a real increase in what I call health literacy around transmission of infectious diseases. And I think we now have, as a population and around the world really, a better understanding of, something like COVID, how it's transmitted through respiratory droplets and why we wear masks and why we wash our hands and all that kind of thing. So if we think about STIs, it's straightforward in the sense that these are microorganisms that are transmitted through sexual contact and different types of sexual contact. The microorganisms that make up a whole lot of different sexually transmissible infections or infectious agents are bacteria, viruses, and parasites mainly. They're the big groups, but within those groups, there's lots of different ones. So the reason it depends as to whether you can catch an STI or whether it can be transmitted without protection. And by that, I'm referring to barrier protection. So things like latex condoms and dental dams. It depends on the particular infectious agent, which part of the genital tract, or even so that the mouth and tongue and back of the throat, which part of those anatomical locations they actually are able to invade and multiply and thrive in order to cause infection. We have microorganisms living all over our bodies and inside our bodies all the time, and a lot of them are really healthy and we need them. But the ones that can cause an infection are what we call pathogens, and they can destroy tissue, damage tissue, and cause symptoms or be transmitted without our knowing. And STIs really are often asymptomatic. So if we take a really common one like chlamydia, which I know you've all heard of, that's a bacteria. It's quite fastidious in that it kind of only really can survive in certain parts of the genital tract and the back of the throat. So the cervix in women, the urethra in men and women, and it can only really be successfully transmitted from one person to another through physical contact with the secretions, genital secretions, so semen, cervical mucus, vaginal secretions. There has to be that actual physical touching. Something like herpes, genital herpes, which is caused by a virus, it creates little ulcers, micro ulcers. Sometimes you can't even see them on the skin surface or the surface of the lining of the mouth and tongue and the genital tract. So in that situation, if you do have the virus living in that part of your body, then it can be transmitted through skin-to-skin contact. It can also live in some of the secretions. But of course, things like the male condom, female condom, and dental dams don't necessarily cover all those parts of the skin and lining of the mouth and genital tract that, where the virus could be living. So that's why there are some STIs where you aren't going to get necessarily full protection, whereas something like chlamydia, you've got a really good chance of it not being able to be transmitted, provided the barrier stays intact throughout all of the sexual contact, is much more likely to protect you from catching something like chlamydia. So that's a very long answer to that question, but I hope I've kind of explained the thinking behind it.
Yeah, absolutely. And I think it is really important that when we're having conversations with young people, we are reminding them of those skin-to-skin infections that we can pick up. And I think because something like genital warts, for example, has really dropped off the radar for young people given the human papilloma virus vaccine that they were offered. We do need to be mindful, particularly of herpes and those skin-to-skin contacts, which can still pass on those viruses. So really good points. Thanks so much for that one. Next question, number 2. It's like a drum roll. Where is the G-spot, and what does the G-spot do? What is it even for?
Oh my goodness. Even after all these years and occasionally being asked this question by Dolly, Dr. Readers, it's still a mystery in some ways. It still actually causes quite a lot of controversy in the world of surgeons and people who study bits of body, you know, and dissect dead bodies to discover them. There's still quite a lot of controversy. So first of all, the G-spot, the G in the G-spot stands for Grafenberg. That was the last name of a German physician and scientist, and he believed that he discovered, or thought he'd discovered, this very highly erogenous zone inside the front wall of the vagina towards the sort of lower end of it. And he described it, but then the word G-spot became a thing in the 1980s. And I was still a young person then, and I remember that being a real thing. You're going, oh my goodness, what's a G-spot, when I was a young person. So so that's kind of where the word or the expression came from. But what actually is it? So there are certainly people with vaginas who have experienced a particular sort of smallish area inside, when there's something inside the vagina, whether it's a finger or a sex toy or a penis, they feel that there's a particular area that's highly sensitive, highly erogenous. They get very turned on, and they might even say that they orgasm. And that's certainly true for many people. But in trying to actually identify, is it an actual physical thing that you could, if you could, you know, kind of draw it, look at it, take it out, if you were able to dissect it, what would it look like inside? Is it a separate tissue? And that's where the controversy comes from. So I think in Australia, I think a great claim to fame of Australia is that there's a surgeon, a urological surgeon called Helen O'Connell, who she didn't discover the clitoris, but she was the first person who really fully mapped it out through all of her PhD work and earlier, in not until 1998, she sort of published this seminal paper about what the clitoris actually looks like. It was far bigger and really a really interesting structure than what I learnt about when I was in medical school. Like, the clitoris was just this little pea-sized thing at the top of the vulva. That's pretty much what I learnt about it in medical school. But Helen O'Connell really described it in a lot of detail, and she still claims, she published a paper just about 4 years ago now, where she still doesn't believe there's an actual G-spot. She believes it's something to do with the fact that the clitoral bulb, so these areas of the clitoris that swell up during sexual arousal, and the lining of the vagina, there's something in the vaginal tissues itself, and even the urethra. In women, she feels that there is a particularly sort of sensitive area there, which she would call the G-spot area. There's another surgeon in America who's published a lot of papers, and he published one more recently, a couple of years ago, where he reviewed the research people have done. And these are people who study anatomy, you know, they're surgeons or they're scientists who actually look at bits of the body. And this surgeon from America reckons there is a G-spot and that he's been able to actually describe it. But the short answer is we don't really know if an actual spot exists, but there certainly seems to be an area that people who, you know, women themselves say that they can locate it, and others say that they can't. So, you know, the G-spot remains a part of, you know, of somewhere inside, probably the front wall of the vagina, that's particularly sensitive.
So best to say that for some people, they should probably keep looking for that map to find the G spot. I think we talk to young people about that too, in that, you know, masturbation is one of those things that even before sexual activity can really help them to identify what their own erogenous zones might be, and then to be able to describe that or explain that to sexual partners can really help with their sexual pleasures as well. So yeah, keep on looking for the G spot, everyone. Next question, please, Maddie. Can you get rid of herpes?
I must say I'm loving these Dolly covers. Aren't they great?
I just feel like
How did you find them all? They're great. Okay, so herpes, and what we're referring to there is the herpes simplex virus. There are lots of different herpes viruses. So herpes simplex virus, type 1 and type 2 are the ones responsible for causing genital herpes. Many of you may know that type 1 herpes was the one that commonly causes cold sores in the mouth that young children get. It's very common. A lot of adults are sort of immune to it. They've been exposed to it over their earlier lives. And type 2 more typically was responsible for the genital herpes lesions. In fact, now it's thought that type 1 is actually more commonly, just slightly more commonly, the cause of genital herpes. So in other words, type 1 and type 2 both cause genital herpes. Now, the virus itself is not curable. There is no medication or drug yet that's been able to eradicate the virus from the body. Whether you've got an acute episode or if you've had it in the past, we know that the virus is able to survive for years, if not decades. The top of the nerve cells near the spine, and that's why people get recurrences. So for various reasons, it gets reactivated and you can get another recurrence of herpes. The sort of full-blown genital herpes infection is often a little bit of tingling or numbness or altered sensation in the skin near the genital area, and then followed maybe in a day or two by a very painful ulcer. And then maybe a day or two after that, it just heals over with no scarring. So that's a kind of typical herpes episode. There are now, and there have been for a long time, antiviral drugs which do help if there's a really, often in the first attack of, or the first primary infection of genital herpes, if antiviral therapy is started soon enough, it will shorten the duration of that primary episode. And these same antiviral drugs can also be used in the case of frequent recurrent episodes of herpes. They tend to shorten the duration and the severity of the symptoms. And they can also be used for what's called suppressive therapy. So if people do get, frequent recurrent episodes of genital herpes, they can go on to suppressive therapy, which seems to actually suppress the recurrences. So been around for a long time, safe, have a chat to GP, sexual health service, and their prescription medications. So that you can certainly improve your quality of life, I suppose, by suppressing recurrent episodes or shortening them when you get them. But herpes is not curable, doesn't go away. And, it has a huge psychological impact on people who get episodes of herpes. I think there's possibly quite a lot of more stigma sometimes attached to herpes as an STI than some of the others.
You took the words perfectly out of my mouth, Mel. I remember when I was a sexual health counsellor that herpes was certainly the one that had the most psychosocial impacts, particularly on young people. If they'd contracted herpes as a young person, how do I sort of negotiate or navigate that in a relationship moving forward? And just to, I guess, touch on the reasons why we might be seeing HSV type 1 more in the genital area. Are you able to elaborate on that for us?
Yeah.
What's the practice that's leading to that?
Yeah, no, that's really important and something that, we need to inform young people about when we're doing any, giving them sort of general information and education around STIs. So it can transmitted through oral sex, and that's the reason why it's now thought that possibly type 1 causes of genital herpes has become more common than type 2. And it seemed to be a trend that started towards the end of the 1990s, where we started to see more type 1 genital herpes from oral sex. And there could be a whole lot of reasons behind that, but one of the things that I know several of my colleagues felt was possibly contributing to it was a kind of flow on from the HIV pandemic of the 80s and early 90s, and lots of messages about safe sex and the possibility that more young people were seeing oral sex as a safer form of sex in terms of protection against HIV. I also believe actually that it's simply that oral sex, which has always been a practice in humanity, just became perhaps less taboo and something that young people felt more comfortable engaging in. And that's something when we look at sexual behaviour studies of young people, so those adolescent years when young people are first engaging in partnered sexual behaviour. It used to be, and perhaps in my generation and older than me, that oral sex was not something that young people engaged in first. They might have had intercourse first, and oral sex was something that came a bit later. It was seen as a little bit more intimate. That's completely reversed now, completely and utterly reversed. So I think that's just been part of a trend amongst young people and what they're comfortable with in terms of sexual activity.
I agree, but I think it highlights the importance for us to still be talking about protection when it comes to oral sex. And indeed, it's one of the reasons why flavoured condoms were developed, because
that's right.
It's usually the only sexual orifice that has
that's right.
blood. So yeah, great response. Thanks for that one. So moving on to question number 4. How long does sex last for? And I bet this was a really popular question back in the day.
Well, yes, but it was a question. There were a lot of questions. The questions about sex were often about these different, not about STIs so much, to be honest, or even pregnancy, but about like, how do you do it? How long does it last? How long should it last? What are the techniques? Because I guess these were young people engaging in these kinds of behaviours for the first time. But I would answer this question, first of all, by saying, well, how do you define sex? And I'd love people's thoughts about that, to be honest, because I think it's time. It's time to say to young people that, sex is not just penis in vagina sex. That's just been an assumption forever. And it's time to turn that around a little bit. However, we've got to answer this question. So I would say the starting point, let's say the starting point is when a person first notices and experiences sexual arousal. If that's how sex begins, are we talking about one person, or are we talking about 2 or however many people are involved in the activity or the encounter? So is the starting point when everybody's becoming aroused, or are we still just referring to one person? How do we define the endpoint of sex? Is it orgasm? Is it the male ejaculation? Is it when everybody in the activity has reached their own version of a climax? And I would argue that, invariably, whether we do it consciously or unconsciously, we always think about sex being from when he enters the vagina and then ejaculates. And that's what a lot of the research has done. When I look up textbooks and I look up papers about the duration of sex, they all talk about the starting point being when the penis enters the vagina and the finishing point when the man has ejaculated. So I can answer that question. There was a recent study that looked at 500 heterosexual couples, and they did exactly that. They, as much as is realistic, but they did their best. When he first entered the vagina, they hit a stopwatch. When he ejaculated, they stopped it. And guess what the variation was? 80-fold variation. So some said 33 seconds, and the longest was 44 minutes. These are 18 years and older, so including up to middle-aged men. But the kind of average or median time was 5 and a bit minutes. Okay, so that's a kind of one answer based on quite a large study, 500 couples, heterosexual couples in various countries around the world. Then a similar study of women, this was over 600 women, also from various countries, timed penis into vagina and her orgasm, and that duration was anywhere between 6 and 20 minutes. But guess what? 2/3 of those women didn't have an orgasm, and the reason being that they were only allowed to achieve their orgasm through penis in vagina sex, no other stimulation. So it's not a very reliable study. However, we do know from, I guess, more like laboratory kinds of studies where volunteers have gone in and agreed to be either filmed or observed when they reach orgasm. And it seems to be that women's orgasms on average last a little bit longer than men. So somewhere between 13 and 51 seconds from when you start the orgasm to when it finishes, and for men somewhere between 10 and 30 seconds. So look, I think that that's a really interesting question to me, because I think that there's so much we need to do to help young people think about sex as something much, much broader, because we exclude anybody there who's not engaged in heterosexual sex. We exclude people with diverse bodies, and we shouldn't, we shouldn't be focusing on how long it takes or how short it is, or think that somehow if you're a guy, the longer you can last makes you a better man. These are the kinds of myths I think that young people are being sold. I think it's more important to talk about consent and pleasure and mutual pleasure, and particularly for young women, to so that they know that they have the right to sort of mutual pleasure, and that penis in vagina sex is not necessarily the way it's going to be achieved.
Yeah, really great points. And I think that was one of the things that really stood out for me when a parent once said that she had a daughter come to her and sort of say, when's the right time to have sex? And she goes, when you're going to get pleasure out of it. Yes. And I thought that was a really good response, because I think that society has tended to that potentially sex is really for the pleasuring of the man, and that the woman has often been overlooked in that. And I also think that because of the nature of porn or pornographic materials these days, there's this unrealistic expectation of people about how long sex actually lasts for, which isn't represented in a realistic way when they're being, I suppose, exposed or educated by those sorts of resources as well. So also something to take into consideration and think of when educating young people around that too.
Yep, no, that's great. Yeah.
Okay, moving right along. Number 5, how do we get rid of genital warts?
Okay. Well, just my little quick microbiology lesson again here. So genital warts, as we know, is caused by the human papillomavirus. There's over 100 types of human papillomavirus, or HPV, and only 2 types, type 6 and type 11, cause 95% of genital warts. So the HPV virus that causes things like cervical or anal cancer are different types. And that's why in some ways, and the sort of more common warts that you get on your fingers and other parts of the body, and young children get them, mostly are not sexually transmissible. There might be a really small number of cases where people think that that has been the case, but we're really talking about 2 types of HPV that cause the great majority of genital warts. Now, we've got, again, an Australian discovery or development of the vaccine, and we've seen a dramatic reduction, almost to zero, in some sexual health clinics, presentations of genital warts, because the HPV vaccine covers type 6 and 11, and that's not all of them do, sorry, but the one that was rolled out in Australia covers type 6 and 11. So that has kind of eliminated genital warts for the great majority of young people. However, if you've been unfortunate, if you're older, or if you've been unfortunate enough to have had genital warts, in a way like the herpes virus, they don't go away. They last. That the virus can last for decades. We do think that natural immunity eventually eliminates the virus from the body, but it is a virus that can just survive in the base layer of the skin. and it might flare up again sometimes when you're under stress or your immune system's just a little bit down. Pregnancy is a good example of that. So pregnant person, their immune system alters a little bit, and sometimes that's when we have seen genital warts flare up, and that can be quite dramatic sometimes. So to get rid of them, so there's prevention, but to get rid of them if you do have them, if the first line recommendation is they're prescription medications, but there are two types of prescription paints or creams that you apply directly onto the wart, and the person with the warts does that themselves. They don't need to go, they get a prescription, but they don't need necessarily to have a clinician apply that for them. They can do that themselves. And then the other method is that commonly happens in sexual health clinics, and I certainly did a lot of that when I worked in a sexual health clinic quite a few years ago, is cryotherapy, so freezing them off. And it usually takes, 2 or 3 treatments before they heal, but there's a really good success rate of the warts actually being healed. And then there's a smaller percentage of recurrence of warts, and you can go back and keep on having them frozen. There are other treatments that involve surgery and sort of what they call ablation. So there are other kind of slightly more invasive techniques that can be used in kind of quite severe cases. But the most common forms are these topical treatments with, there are 2 types of drugs that will sort of destroy the warty tissue, and freezing them, or cryotherapy.
Wonderful. And I think the really hot tip there is don't try to self-treat with an over-the-counter wart off or something like that, because it's probably going to do more damage to your genitals than curing that virus itself. So, or managing and treating that virus itself. So thank you for that one. And great now that we have less young people experiencing genital warts. So what is the clap?
Well, when I was young, the clap referred to gonorrhea, and I think it still does mostly, but I think there have been uses of the word the clap to just refer to any STI. Sometimes it's even, I think, been referred to herpes sometimes. But yes, I'm going to answer this question referring to gonorrhea, which is another bacterial STI. Now, gonorrhea is much less prevalent in Australia than something like chlamydia, except in certain populations. So gonorrhea is more likely, not more likely than chlamydia, but it's much more common to see it in men who have sex with men, and in young populations of young Aboriginal and Torres Strait Islander people, particularly those in remote parts of the country. And the other population that we see gonorrhea in more commonly are people who have returned from overseas, where they've had sex with people in countries where there's a lot more gonorrhea around. So it's one of those infections that really varies with country and region and population. And that's true for a lot of communicable diseases, in fact. So gonorrhea, like chlamydia, it infects similar tissues to what chlamydia does. It is more likely than chlamydia to cause symptoms, and that's like a vaginal discharge. In a man, it's a discharge from the urethra. That can be quite painful, but it can also be asymptomatic. And in fact, I would say in the last few years, most of the gonorrhea that I've picked up in the clients that I see have been asymptomatic, and we've just been sort of screening them. Chlamydia is very likely to be asymptomatic, gonorrhea much less so, but we do see it asymptomatically. Now, as probably many people know, something like chlamydia is easily cured and gotten rid of with 1 dose of antibiotics for the great majority of people, if it hasn't become a complicated infection. And by that, I mean hasn't gone up into the pelvis and caused problems with pelvic inflammatory disease, and in the man gone up into the epididymis and cause more complications there. Gonorrhea similarly can cause pelvic inflammatory disease and can cause infection of the epididymis in men and further things as well. But it is treatable with one dose, usually just one dose, but it's a painful injection. And you also have to take oral antibiotics. The difference with gonorrhea, unlike chlamydia, is that we are seeing, in fact, not just starting to, we have seen for a while, the development or the emergence of antibiotic resistance to gonorrhea. And that's why, if possible, even though we can pick up gonorrhea with the same urine test as chlamydia, in an ideal world, if we do diagnose gonorrhea in a person, if at all possible, we should try to get a swab and send it off to a laboratory to have the culture and sensitivity, the antibiotic sensitivity looked at, because that's the best way for us to see whether we're seeing these patterns of resistance developing. And it's, likely to become a really big problem, because if we get to a stage where all the best antibiotics for gonorrhea are now, there's resistance to them, we start to get into trouble. So it's just something that I think certainly New South Wales Health, but also everywhere around the world really, are starting to take notice of and be concerned about.
Absolutely. And is it true that as individuals we can avoid some of that resistance? So, for example, a lot of people might be prescribed an antibiotic that's a 7-day course. They get to day 3 and they start to feel okay. So then they don't take days 4, 5, 6, 7.
Yeah.
Is it true that we can start to avoid some of that resistance by taking those full courses and not just cutting it off when we feel better?
Yeah, that's part of certainly the general wisdom, but also the scientific evidence that if we only partly treat an infection, we might eliminate the symptoms, but we allow the bacteria to sort of grumble on at a lower level. And of course, bacteria, as we're seeing even with COVID viruses, all these microorganisms are really smart. They mutate a little bit, they become resistant to things. So that's absolutely one reason why, when the doctor writes a prescription, says take the whole course, it's not just because they, they think it sounds good, or it's because there is some evidence that it can contribute to the development of resistance, in the same way that taking antibiotics willy-nilly when you don't really need them, and doctors are responsible for example, over-prescribing antibiotics when people have a cold, just a common cold or a sore throat or a head cold. Most of those are caused by viruses. Antibiotics make no difference at all. So the medical profession is also has contributed to the development of resistance through unnecessarily prescribing antibiotics.
Right. Great response. Thanks, Mel. Number 7. I just can imagine how many questions came in around this, and it was like the holy grail of, when it meant to be a young person. But how is it that a woman orgasms, or how is it that an orgasm is brought on for a woman by self or others?
Yeah, really important question. My favorite question. And look, in terms of the questions that came into Dolly Doctor, most of the time the questions from young women were that they weren't achieving orgasm when having sex with their male partners. And it didn't come from young women who are having sex with other women. So that already tells me something. And so my first answer to this question is, who's asking the question? Is it a young woman seeking to pleasure herself and discover her own body and figure out how to give herself an orgasm? That's great. Encourage that all the time. Yeah. Is it a young woman like the ones who would write into Dolly Doctor, who has been having sex in different ways with a male partner and is not achieving an orgasm, but is able to do it when she's on her own? That tells us something else again. Is it any person of any gender who's curious about this? So I think whoever's asking the question and why is important to know as well when answering this question. And again, I'm going to sort of a little bit of a soapbox, but I think we, as I said earlier, when I was the question about how long sex lasts, I think we still live in a world that privileges male orgasm over any other type of pleasure or orgasm. And we still live in a world that depicts unrealistic sex scenes between people in mainstream media, mainstream entertainment, and also mainstream sexually explicit material. And as we know, younger and younger children and adolescents are viewing online pornography, and most of it privileges male orgasm over females. I'm not saying all porn is like that, but that's what most young people are seeing, and what most young people are being exposed to before they even come close to having intimate encounters with another person. So it's no wonder, I think, that young people, and especially young women, just aren't quite sure what's going on and why they can't have an orgasm. And I also think young men, you know, we're not doing them any favors either, you know, because they're finding themselves a bit stuck, maybe also wondering what's wrong with their bodies when what they see in porn isn't quite what they think it should be for themselves. And also if they're heterosexual and they're wanting to enjoy sex with a female partner, young men also aren't quite sure what to do because they're not learning that from porn either. So the short answer to the question, though, is that there's no one way to make a woman orgasm. As we said earlier when talking about the G-spot, for most women there's a whole area, and it varies from woman to woman, from encounter to encounter, and it even changes within one sexual encounter as to what part of their body, their genital tract inside the vagina, is most sensitive at that particular moment. So sensitive to touch, whether that's with fingers, a toy, a tongue, penis, whatever it is, that the parts of the body that are particularly sensitive and most likely to increase arousal intensely is just going to be variable all the time. But the common areas are, number one, probably the clitoris, the glands, or the sort of tip of the clitoris. That's probably the most sensitive part of a female's anatomy. But also around the vulva, the opening of the vagina, as we said with the G-spot, up on the front wall, further up inside the vagina. Also the nipples and the circles around the nipples and the breasts in general. The mouth and the tongue, they're erogenous zones. Places like the upper thighs, the skin, the earlobes, the neck, you know, it really varies. And so all touching, stimulating, caressing, all these different parts of the body can help achieve an orgasm for a woman. But, you know, touch alone, physical touch and rubbing alone is not necessarily going to bring on an orgasm if there are other contextual factors that are operating at the time. So if she's very stressed, if she's in a situation she's not that sure about, if there's been issues with the partner for whatever reason, if the relationship or the history of the relationship or her history of relationships, all of those things can influence her experience of pleasure, arousal, and orgasm at any one particular time. And that goes for everyone, not just for women, in fact. So I guess my answer to, let's say, a young person who wants to have an orgasm and a pleasurable experience with another person, it's really good for young women to you know, to discover their own bodies themselves when they're by themselves. It's really safe to masturbate and just kind of figure out all the different parts of your body and what turns you on. And then if and when, you know, you're having an intimate encounter with another person, to communicate that, for the couple to be able to communicate what feels good, what doesn't feel good, how to change that. And I think that's something I always try to answer in a very short number of words in answering this question in Dolly Doctor. It's quite difficult in like 150 words, but it is about, you know, learning what feels good for you, and also learning how to communicate that and to hear from your partner what what they want as well. And certainly trying to mimic what you see online is mostly never going to cut it. That's another kind of really important message.
Yeah. And I think just to add to that, normalizing female masturbation as a way to have those experiences and to learn, because I think that, we're quite open to talking about male masturbation. And in fact, we quite often joke about that, whereas female masturbation still has a lot of taboo and it's not something that's openly discussed. So being able to speak to young women about that's a completely normal, natural and healthy way to start your sex life is not a bad discussion to be having either.
Yeah, and it was a really common question from very young adolescents who wrote to Dolly Doctor. And this goes back to the very first, batch of questions I ever answered in 1993. There's been no change in the number of young adolescent girls who enjoy masturbation and would like to know, if it's okay or not. So
yeah. And I think that's the funny thing that's sort of coming to, answering all these questions, that what it was that we were seeing 20 years ago is still really relevant in 2021. And, have our discussions changed? Like, we're still asking the same questions. Does that reflect on the fact that the way we're providing that education and information needs to change to better align with what it is that young people are actually wanting to know about all things sexual health and relationships? And yeah, definitely something to be thinking of, especially as health promotion officers, how we're getting those messages across, or even those who are online today working with young people. How do we start those conversations and feel really comfortable about talking through some of those things that, are still very relevant today, as you've pointed out. Number 8, how do we get a bigger penis manually?
Dolly Doctor didn't receive a lot of questions from boys, but of those that did come in, guess what the most common question was?
How do I get a bigger penis?
It was about penis and penis size and how
does
it all
size
works.
really matter?
So for people who have a penis, you'll know, most will know that it gets bigger in certain situations. Usually it can happen in your sleep. It can happen if you're just having arousing thoughts and fantasies. And of course, it can happen with physical touch and stimulation if you're in the right mood. But I think this question is probably more referring to increasing the size of your penis, regardless of whether it's aroused or not. And like I said, it was the biggest preoccupation of the boys who wrote into Dolly Doctor, and that's not a good enough sample to say this is what lots of boys are preoccupied with, but it certainly, I think, reflects something. I felt concerned all the time actually writing questions. There would be some questions about body image and weight and things from girls, but I was increasingly seeing concerns about genital body image, particularly as online porn became more and more ubiquitous. And girls were removing their pubic hair because that's what porn showed, and then taking notice of their vulvas and real concerns about what they look like. And I think for boys, probably this is also, what they're seeing on porn is very unrealistic, and it's distorting their own genital body image as well. So there is a huge industry out there making lots of money selling to boys or young men, probably more, how to get a bigger penis, and they don't work. So the penis enlargement pills, and that might include herbal things, vitamins, some with hormones in them. From all the studies I've read about, none of them actually work. There is a type of vacuum pump, which was kind of developed to treat men with erectile dysfunction, which is a thing, of course, and that will help create an erection. But that's for erectile dysfunction. It doesn't change your penis size in any permanent way. There are penis extender devices which help stretch the penis, which apparently can work sometimes, but it's a little bit, I guess the urologists and the specialists who know about penises say they're not that great. 2 types of surgery. One injects fat cells and increases the width of the penis. The other one cuts a ligament, which can make the penis look longer. Again, the experts, which I don't feel I am in terms of penis enlargement, say that these are not great options, really. So, I mean, and the other thing, before we had medications like Viagra, was that men who did experience problems with erection were given things like manual pumps and other devices that they could use to help them achieve erection. But I think, you know, the availability now of medication has kind of revolutionized that sort of treatment. So, look, in other words, you know, there's no need to increase your penis size. I'd like to say that to all young men, or all men, you know, it really, size doesn't matter. But I understand, just like for young women as well, that there's a lot of, I guess, just mythology attached to our genitals and different parts of our body, particularly the parts of our bodies that are sexual, you know, that kind of help us identify with our sexuality. I think we do get hung up sometimes on those, and how to undo that kind of thinking can be really difficult. But, you know, I just want to reassure young men that, you know, if you talk to your partners, the great majority of them aren't going, whether your partners are whatever gender they are not going to care. It's much more about the encounter and the interaction and a whole lot of other things.
Absolutely, and not necessarily that you know, a larger, thicker penis is what's going to achieve orgasm for any gender either. That's not necessarily the case, and probably a well-held myth, and that in fact for some people they won't be able to tolerate that larger, wider penis.
Exactly.
So yeah, really well answered. Thanks, Mel. Should I be worried if my partner still likes adult movies? And I'm assuming that by adult movies, they're referring to porn as opposed to, you know, adult movies versus cartoons. But, you know, questions came in where you really had to process it sometimes and go, what is it that they're actually asking? What do they mean by X, Y, Z here?
I know, and that was true in a lot of Dolly Doctor questions. So I had to sort of say, this is what I think you mean by this expression. And adult movies is it's sort of a quaint, old-fashioned expression, I think. I feel like it's the sort of thing my grandmother would have said. So the answer to this is, again, it depends. I think it's important to acknowledge that it's a kind of natural aspect of human sexuality and in its diversity that many people enjoy watching other people have sex. Okay. And of course, for the majority of people, that's through, films, you know, filming of people having sex rather than actually physically watching other people have sex. Although, of course, that happens too. And over history, that's happened in lots of different ways. So it's a kind of natural aspect of human sexuality. But when there's a couple and one person, you know, there's a whole lot of possibilities with this question where it might be something to worry about. And that is if you feel that your partner is perhaps starting to view porn in a compulsive way. And I certainly see young people who are really quite worried about their own pornography consumption, that they've become a little bit obsessed with it, that they feel a little bit addicted to it. And, you know, there's no sort of right or wrong answer to how much is too much. The answer is if it becomes a problem for you. In the case of a relationship, if it becomes a problem for the relationship, then it's about talking that through and resolving it. I think a lot of young women, particularly those who wrote to Dolly, were worried that it meant there was something wrong with them if their partner enjoyed watching porn, so their male partner enjoyed watching porn. And that's something, again, you know, that's not the case. Like, lots of people enjoy watching porn for perfectly normal reasons, but it can be a problem in a relationship when either there's a kind of imbalance or one person feels that it's a problem. However, I will say that there's been more and more research, particularly in recent years, that's expressed a lot of concern about the impact that watching porn is having on heterosexual sexual activity. And that is that a lot of the kind of mainstream, readily accessible porn that young people are viewing tends to depict acts that some young people and particularly young women, see as violent. So hair pulling, a bit of slapping. I mean, these kinds of things might be fine, but what some of the research now is starting to show is that men are thinking this is what they're supposed to do. Women are thinking this is what they're supposed to enjoy, and they're just really not. So I think we're doing our young people, again, a really big disservice by allowing pornography to be the default sex educators. We need to be, you know, giving young people a whole lot of other information, images, descriptions of how to enjoy sex that's not just what you see in porn.
Yeah, so again, that reality versus perception, that whilst that might be what you're seeing in porn, you're perceiving that that's what a particular gendered partner might like. What it comes down to is having those conversations. Like,
that's right.
Would you like to experiment with me and trying blah? Could I do this? And really working on that consent, as opposed to this is what I've learned and think that this is acceptable and okay. And again, it comes down to those discussions, doesn't it? And just really being able to, comfortably have those discussions with young people about what to potentially expect and what it might be like versus what they've seen in porn, because we know that it's not reality.
That's right. Yeah.
And last but certainly not least, number 10, is it unhygienic to lick your partner's bumhole?
Okay, well, coming back to microorganisms again, the skin around the anus is part of the genital, the genital system. It's an erogenous part of the body for people of all genders. And so licking the anus has been in practice forever, for as long as humans have been having any kind of sexual encounter. It's an enjoyable practice by some people, okay? So the hygiene aspect of it is about what are the kinds of microorganisms that you might become infected with if you do this. So it's a form of oral sex, if you like, to lick someone else's anus. So as far as STIs are concerned, all the ones that infect the genital skin, herpes and warts, they will also potentially be transmitted through analingus, or licking the anus. So the same kind of principles apply there. But then, of course, the anus and the skin around the anus is naturally going to have, always have the presence of some of the bacteria that live inside the gut. And it's very likely that that happens. And that's, for example, when we talk about, just digressing for 1 second, why in heterosexual encounters, young women can get urinary tract infections that come from the E. coli bacteria, often that comes out of the intestine, sits near their anus, somehow it sort of gets up into their urethra when there's a whole lot of friction. So E. coli and other bacteria that live in the gut can also be obviously swallowed if you're licking someone's anus, but actually they're not those ones. Those sort of healthy bacteria aren't really going to probably make you sick at all, even if you do swallow some of them. The ones to be concerned about are the pathogens that we know can cause infection. So hepatitis A, which is a virus. There's a bunch of parasites like giardiasis. There's salmonella and campylobacter, which are bacteria. Those cause infections of the gut. They can cause nasty gastroenteritis. So if somebody's got any kind of symptoms of that, or might have that, then you should probably avoid having anal oral sex or analingus. But tips are just like cleaning the area really thoroughly. You can use dental dams as a barrier protection, washing out your mouth really well afterwards, probably with an antibacterial mouthwash. These are kinds of practices to minimize any transmission of an unwanted pathogen.
Perfect. Really well answered, Mel. And I guess the key point to take away from that is don't ever yuck somebody else's yum, because you just don't know what people are interested in. So that brings us to the end of answering the questions, and I think we're pretty much right on 11 o'clock. So we've done perfectly.
Amazing. Rush through that.
From Caddyshack, we'd like to say a really big thank you to everyone who's joined us online this morning, and a special big thanks to Dr. Melissa Kang, who's always been so willing to work with us and has been a wealth of knowledge. And we look forward to continuing our work with you and to celebrate the success of the book, Welcome to Your Period, and also once Welcome to Consent comes out. Just can't wait to see it hit the bookshelves, Mel. I'm so excited for you and Yumi. We do have some time for a few quick questions. If there's any that you want to pop into the chat box, we're happy to answer those for you. If not, please keep an eye on your email to get the update after this webinar. And as I mentioned, if you'd like to take a few moments to complete that survey, we really appreciate the feedback. It helps us to know what you're interested in and continue providing these webinars to you. So thank you very much for joining us online this morning. Thanks, Mel. And if there's any questions, pop them in the chat box. If not, have a great day and we'll see you online soon.
Thank you so much.
Thank you so much. Thanks, Mel. That was fantastic.